Leong Center, Leong Center and Child Health Evaluative Sciences rounds. We're really delighted to welcome Dr. Stephen Patrick. I won't read all of his bios, but just a few notable things. Dr. Patrick's a practicing neonatologist and an associate professor at Vanderbilt University. He directs the Vanderbilt Center for Child Health Policy, and he's the executive director of Firefly, which is a comprehensive treatment program for pregnant people with opioid use disorder. Dr. Patrick is one of America's foremost experts on the opioid crisis as it relates to pregnant people and their children and families. He's an advisor to the White House on their national drug control policy, and we're really delighted that he is here to present to us. As many of you know, one of the pillars of the Leong Center is how research can inform policy, and really delighted to hear about his work. As Dr. Patrick is definitely going to leave time for questions, so maybe just put questions in the chat, and if there are not too many of them, I'll call on people so that we can try to have a proper dialogue in the way that we can over Zoom at the end of the session. And so with that, I will pass it over to Dr. Patrick.
Well, thanks for such a generous introduction. It's really wonderful to be with you all today, virtually. Hopefully sometime we were just talking about this at the beginning, get back together, we can see folks in person. But looking forward to talking to you all today. I'm going to watch the clock and make sure that we have good time for discussion. But today I'm going to talk a bit about this issue, and it is going to be mainly US centered. So first, I have no conflicts of interest to disclose. So for me, as a neonatologist, the opioid crisis began here. When I was in training, I started seeing, in our NICUs, we started seeing more infants having opioid withdrawal, and there really hadn't been a whole lot that we had seen at that point in kind of the recent years focusing on this population. It was something that seemed to be flying under the radar in terms of a complication of the opioid crisis. And the complexity of the opioid crisis just seems to play out time and time again when I'm when I'm working in the neonatal intensive care unit. I think back to a patient that I saw a couple of years ago. An infant that was transferred up to the NICU at about 48 hours, irritable, jittery, rapid weight loss at about 10%, jaundice, really had classic signs of drug withdrawal. And when we talked to mom, she denied any substance use. And then I'll never forget, about 5-6 days after the baby was born, walking into the mother's room because we had gotten the umbilical cord testing back, and it was packed for buprenorphine, a medication commonly used to treat opioid use disorder. And when I talked to her about it, the first thing she said to me was, "Are they going to take my baby?" If you step back at this whole situation, you can see it sort of playing out. We have a system that's in place that first does a poor job of detecting substance use disorder, but also propagates stigma and doesn't create an environment where people feel willing to talk about their substance use disorder. And in part, that's because of that fear of child welfare involvement. And then you have a pregnant person who was diverting a drug for treatment. And why is that? Why is it that we are in, this is a couple years ago pre-pandemic, but why is it that we are in a place where people are having to divert drugs commonly used for treatment? And we'll unpack that a little bit too. So today I'm going to talk about substance use and pregnancy and treatments. We're going to focus on neonatal abstinence syndrome for a little bit, or neonatal opioid withdrawal syndrome for a little bit, talk about communities and trauma, and then talk about some of the changing child welfare policies. And we're going to try to talk through this kind of at the bottom here. You can kind of see the cadence of how I'm going to go through this. So first, starting prenatally or pre-pregnancy. So in the United States, and I'm going to assume that it's not that dissimilar in Canada, substance use is not that uncommon. So when we compare pregnant versus non-pregnant people, you can see that I'm trying to use gender neutral terms, and I beg your forgiveness back and forth as our sort of slides are evolving. But illicit substance use in pregnancy is not that uncommon. About 8.5% of pregnant women, that is still far less than non-pregnant women. By far the highest rate, the highest portion is is from marijuana, but you can see the other substances as they fall through. But the other part of this too that I think often gets missed are legal substances like tobacco and alcohol are still very common. And we focus on one drug or the other, but alcohol is the #1 cause of preventable cause of developmental delay in kids. And there's oftentimes a lot of alcohol co-use, and there's just not enough focus on this as we sort of pick our substance of the day to a certain degree to talk about. 5% of pregnant people in the United States still binge drink. That's a high proportion and something that we need to be mindful of. But certainly this is what the context of what's happening in the US. What we've seen have been 3 waves of overdose deaths in the US. The first was from prescription opioids, then a rise in heroin, and then I'm sure you're all following kind of the rise of synthetic fentanyl that is just skyrocketing and kind of permeating every community, including my own. And this is in part why we've seen a record number of overdose deaths in the US. We've topped 100,000 annually over the last year. And each month as the CDC has updated these data, it's still 100,000. This is the context that we find ourselves in. Well, we know that there's a treatment for this. So medications for opioid use disorder like buprenorphine and methadone, they're recommended to treat opioid use disorder in pregnancy. And why is that? It's because we know that it comes with decreased risk of overdose death, relapse, hepatitis C, and HIV. For infants, they're more likely to go to term and to have higher birth weights, though it does come with some risk of drug withdrawal. When I'm talking to folks about this, I usually talk about this. If you are a pregnant person injecting heroin, you're going from intoxication and withdrawal, That's tough on you. It increases your risk of overdose and overdose death, but it also is stressful for the fetus. And so what medications for opioid use disorder do, they level that off. So what you're essentially training are a very preterm infant that's going through this cycle, the risk of preterm birth, for a term infant who has drug withdrawal. And it's certainly better if we think about long-term developmental outcomes to have a term infant born with drug withdrawal than it is a 25-weeker, for example, that is born preterm because mom is injecting heroin and couldn't get into treatment. So we know, just like the woman that I mentioned before, that many pregnant people in the US have a hard time accessing treatment. And in one of our studies, we wanted to find out why, what was happening on the ground. And so we did a randomized field experiment. This is a secret shopper experiment in 10 states in the US to understand what was happening kind of at the ground level. To gather data, we looked at government lists for treatment locators. So this is one from the Substance Abuse and Mental Health Administration that lists buprenorphine practitioner locators in the United States, one of the medications for opioid use disorder. So we had a pretty big list in those 10 states. We had 10,000 secret shoppers, almost 30,000 phone calls that were made during the secret shopper field experiment. Here's the first thing that we found. First, our big drop off here was just in the reliability of the list. About 25% of the numbers were bad for various reasons. Sometimes we would call, like you can see here, a jail, or even it was a provider's cell phone. But another 20% were a medical office that didn't provide addiction treatment, suggesting that in the US, at least, you've had to get training until recently to be waivered to prescribe buprenorphine, that many people were doing the training, but then not actually prescribing. Of our completed calls, our secret shoppers, there were 3,400, and you can see our randomization scheme worked out pretty well, pregnant versus non-pregnant, as well as we made kind of identical patients Medicaid or private insurance. Importantly, when they called, they were in a specific county. They had the names, the most common, both public and private insurance in that county when they called. We could talk about some of those methods too in the Q&A. But here's what we found. First off, we found that pregnant people were less likely to be accepted for treatment than non-pregnant people. Overall, under buprenorphine providers, these are outpatient buprenorphine docs, about 17 percentage points less likely to be accepted. And this varied substantially from state to state, where you see the gap bigger in states like Kentucky and more narrow in states like Virginia. Opioid treatment programs, these are essentially methadone clinics. we found no difference in opioid treatment programs. But in the United States, opioid treatment programs are far more rare. Where we've seen the expansion and access to treatment in recent years has really been among buprenorphine prescribers. And what about insurance? So when callers called, they were either pregnant, non-pregnant, and they were randomized to either have Medicaid, which is, you're probably all familiar with Medicaid, but it's a safety net program, both federal and state, financed and implemented at the state level. They had one or the other, Medicaid or private insurance. And if that was not accepted, then they reflexed to pay for cash. We've had very low rates of insurance acceptance. About 40% overall of callers overall were able to get in either with their insurance or with cash. We found overall about only a quarter of providers would only take cash for treatment. And in some states that was more substantial. You can see Florida and Tennessee, the state that I'm in, only about 20% were able to get in with their insurance, the insurance that they called with. This was also true for opioid treatment programs. The treatment's really hard to get, even though it's evidence-based. Like there's no doubt that these medications improve pregnancy outcomes, but on the ground, it's really hard to access, just like what my patient was experiencing. The community and state context matters. We've done a couple follow-up studies from this. So again, Medicaid is a state and federal program that is, each state receives funding to their Medicaid program based upon kind of an old formula, but it's based upon the per capita income in those states. So states that are poorer get more federal money than states that are wealthier. We found that when we looked at what was the prevalence of Medicaid in that community, when callers called a community with low Medicaid prevalence, there was a big gap between private and public insurance. That went away in areas where there was higher prevalence of Medicaid. We also wanted to look at state laws. There are some state laws on the books that you can't discriminate against a pregnant person in accessing treatment. We largely found those to be, it was a small sample of 10 states, but we found those to be, that they didn't enhance treatment access. And here's kind of what this looked like. This is without a law that forbid for buprenorphine providers, without a law that forbid discriminating against a pregnant person. You see still non-pregnant people are still far more likely to get into treatment. But when we called, we had callers who had pretty substantially negative experiences. When we first put together the study, we hadn't intended on doing qualitative work with it. We had callers documenting their experience afterwards, and it was in our kind of study process that we heard just some staggering experiences by patients. Here's one. People don't, this is when callers called, and this is just the first person they talked to, oftentimes the receptionist at the front desk. People usually don't show up to their appointment because they decide they want to have one last hurrah and dope before coming. This is what someone was told on their initial call to get in. Absolutely not. We wouldn't treat you. Someone said this to a pregnant person. Whoa, we don't do that here. I won't get into that mess again. Direct quote, also to a pregnant person. Another person was told they would, if they didn't follow the protocol, they could go into convulsions and possibly kill the baby. Again, initial phone calls, and we saw all kinds of experiences that families had, that pregnant women had. So accessing treatment in the US, particularly among outpatient buprenorphine providers, is really difficult. And so what we hear from patients, and there's no data to really, not data that I'm aware of, that patients are diverting buprenorphine in part because they can't get access to treatment. So when they start to go through withdrawal, they're worried that they'll get dope sick and they'll divert buprenorphine. That is an area that needs some study. Government lists of providers are not accurate, should be audited, but stigma is pervasive and we still have a lot of work to do to counter it. Laws to prioritize pregnant people don't appear to be effective, again, in our study that was a small sample of states. Okay, moving ahead to opioid withdrawal. And I will say this, that for me as a neonatologist, this work really started with the infant, and I'm pretty convinced that the most effective intervention you can have to improve outcomes for the infant is to focus on mom first, focus on pregnancy and enhancing access to treatment. Here you'll also hear, I'll go back and forth a bit on language, neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. folks feel very strongly about these two terms. I sort of use them interchangeably as opioid withdrawal. It can be opioid, it's almost always opioid withdrawal. Sometimes it's opioid withdrawal with another substance. So neonatal opioid withdrawal is a postnatal withdrawal syndrome experienced by some opioid exposed infants. Importantly, not all. There are multiple factors that go into if an infant develops drug withdrawal. So prenatal factors can be associated with severity of drug withdrawal or development of withdrawal. Things like additional exposures, benzodiazepines, gabapentin, for example, cigarette smoke, those things matter. Lack of access to treatment, at least in our locally in our treatment group, for infants who are born with moms who are in treatment, they tend to have less severe withdrawal. Also an area that needs study. Postnatal factors are also studied with the development of drug withdrawal and severity. And there's some data to support these assertions too. Lack of standardization, and I'll show you a slide on that here in a minute, that when hospitals don't have a protocol on how they manage, infants tend to have much longer lengths of stay. Exclusion of mother, so not allowing rooming in and not allowing breastfeeding. We know that breastfeeding is an intervention that does decrease risk of drug withdrawal. The clinical features of drug withdrawal in infants is where the opioid receptors tend to live. So common gastrointestinal signs, poor feeding, vomiting, loose stools. This can lead to dehydration and poor weight gain. Some common central nervous system signs, tremors, hypertonia, irritability, and decreased sleep, exaggerated reflexes, and then some autonomic signs, tachypnea, yawning, and dilated pupils. So when I'm talking to folks, I usually describe a baby having drug withdrawal as a colicky baby times 5. You can usually pick them out. They're more irritable than other infants in the certainly in the neonatal intensive care unit, where there are sicker infants often. So what's happened in recent years in terms of drug withdrawal? These data, this is a study that we published with some colleagues at the U.S. Department of Health and Human Services using data from 47 states. And we wanted to understand just the trends of what's been happening and look at some state variation in the last few years. So no surprise, much like that graph that I showed you earlier, we see an increase in neonatal abstinence syndrome or neonatal opioid withdrawal syndrome over the last several years. And if you go back further to 2010, there's about a 7-fold increase in the number of diagnoses of drug withdrawal. In parallel, maternal opioid-related diagnoses, this is opioid use disorder, as well as overdose that we see. That has grown, and we see a little bit of a detection change in the maternal diagnoses around the ICD-10 transition here in the US. It's not an even distribution. We see states around Appalachia where these are kind of, you can see the sort of middle part that's redder are Appalachian counties. These are rural counties. So states like West Virginia have had the biggest increase and the highest rates. The upper Northeast, where you see Maine, New Hampshire, and Vermont, also very high levels. And again, here's the percentage change. This is overall incidence of neonatal abstinence syndrome, and here's the percentage change. So we've seen growth in states like Oklahoma, for example, where there still isn't a high number relative to states like West Virginia, but still you see a large growth. So to treat drug withdrawal, our goal is to control withdrawal. So if you have an infant who's irritable, you want to make them comfortable and prevent any complications like seizure. This begins with non-pharmacologic interventions like environmental controls, allowing mom to room in, breastfeeding. For severe withdrawal, we use an opioid to treat. Morphine or methadone are by far the most common. Buprenorphine can also be used, but is a little less common in the US. And in our systems, we treat about 20% of infants that are opioid exposed with drug withdrawal. And I'm not going to talk about some of our clinical program changes in the slides, but since we've changed our clinical practice to keep moms and babies together and really have family-centered care, we've decreased the proportion of infants that we treat with medications. There have been some recent care innovations in the space. So Eat, Sleep, Console. With my sort of view of the lay of the land in terms of clinical management of drug withdrawal is that it's not terribly clinically complex to treat. And we've sort of over-medicalized it, where we have a complex scoring system that was developed in the 70s, wasn't validated, and mostly I think it could be a little bit simpler, and that's what we see with Eat, Sleep, Console. It's basically asking the question, can the baby eat, can they sleep, and can we console them? Then they're probably okay. We know that there are lower rates of use of morphine compared to the traditional scoring systems. That's called the modified Finnegan, but it really needs more study. We don't know a lot of the long-term effects, and there is an NIH-funded study right now looking at Eat, Sleep, Console. Rooming in, this seems like it, this is not a high-tech intervention, but keeping moms and babies together is associated with lower rates of pharmacotherapy and shorter lengths of stay. And I certainly have seen this in my clinical practice too. There has been a look at various medications, so looking at methadone versus morphine, and then buprenorphine versus morphine. And in both of those randomized controlled trials, the methadone and buprenorphine were associated with shorter lengths of stay when compared to morphine. We also know standardization works. One of my favorite studies in the space is now, again, to be a little bit of an older study. The Ohio Perinatal Collaborative had a multi-center cohort using data that they had collected for their quality improvement efforts to look at the effect of methadone versus buprenorphine on length of stay. And what they found was no change by medication, but centers that had a strict protocol, those centers had about half a length of stay. Similarly, the Vermont-Oxford network that includes a lot of centers both in the US, Canada, and beyond. And in this effort, there were mainly US and Canadian hospitals involved, worked to standardize care for infants with opioid withdrawal. And what they found was standardization associated with improvements in both shortened length of stay as well as length of treatment. So NOWS has increased pretty substantially over the last 2 decades. I do worry that we still focus on NOWS as a diagnosis. I mean, I did in the first few slides, right? Because we have data for them. But we miss an opportunity to really talk about opioid exposed infants. There's not good evidence to suggest that an opioid exposed infant who doesn't receive a diagnosis of drug withdrawal has a different trajectory than one who does. And so this is an area that needs study, and our group is doing some of that. Standardizing care, rooming in, does appear to improve outcomes. Well, I want to take the next little bit to talk about communities and the role of communities in outcomes for families. So I'm from a town in southern West Virginia. If you remember back to that map, that is a state with one of the highest rates of drug withdrawal. It also has consistently the highest rate of overdose death in the US. Just before the pandemic, I drove through my hometown and took a couple pictures of downtown. And this is what downtown looks like on a Friday afternoon. When my grandfather here didn't have a high school education, but he had a pretty stable job on the railroad. Those jobs have gone away or changed in that time. And what we've seen too is that this county has an overdose death rate that's about 3 times the national average. State reporting finds about 3.5% of infants born in this county are diagnosed with drug withdrawal. And so we know that West Virginia in particular was really targeted by drug companies at the beginning part of the opioid crisis. But the calculus is probably more complicated. If anyone has read the work of Case and Deaton and their Deaths of Despair, they published their book just as the pandemic was occurring, but had multiple studies beforehand. But the general tenet is that the increase in deaths that we see from opioids, suicide, alcohol-related deaths are at least partially tied to lack of economic opportunity, social fabric, things like that. We wanted to understand if these factors also played through for maternal child health, for diagnosis of drug withdrawal in particular, and I'll share with you some data here from this study. So here we looked at multiple factors for 580 US counties in 8 states. And in the bottom right, you'll see the states that we focused on. And here's just some county level data. These are rates of drug withdrawal in these counties. And I'm just going to play them forward so you can see how they spread in recent years. So you can see the middle part of this graph really getting darker blue. These are disproportionately rural and Appalachian counties in this community where we see things spreading. If we overlay long-term unemployment, so we used a moving average of unemployment for the last 10 years to understand what's happening now in communities in terms of unemployment, also the last decade. So if you overlay them, the bottom right are the counties that have both high long-term unemployment, high neonatal abstinence syndrome. What you see are, again, disproportionately Appalachian counties that fit that, just showing some of the calculus of how things are. So in these communities, this happened during part of the Great Recession. We saw the 10-year moving average of unemployment increase from 6.5% to 8.2%. And this was associated with higher rates of neonatal abstinence syndrome, particularly in remote rural counties, with about a 2 percentage point increase in long-term unemployment associated with a 34% higher rate of drug withdrawal in those communities. Counties with mental health shortage areas also had higher rates of neonatal abstinence syndrome. And that was particularly in urban communities. We have these data on our website, by the way, too. You can, our website's childpolicy.org. We have a couple different things there that you can log on and see, including our non-opioid related work, and play with the data with the Shiny app that we have online. I just wanted to mention this too, because hepatitis C is another condition we've been looking at. Oftentimes, at least until recently, feels like it's also flying under the radar. Nationwide in the US, about 2.5 million people are infected with hepatitis C. There are nearly 500,000 acute hepatitis C infections in 2017. This isn't just about baby boomers. That's really been the narrative until recently. We've seen an increase in younger population that's really been associated with injection drug use during the opioid crisis. This is now really bimodal in the US. Exposed infants have to be followed to see if they have seroconversion, see if they're infected with hepatitis C. The vertical transmission rate is kind of low, 6% for vertical transmission, 11% if there's co-infection. But maternal antibodies can persist for 18 months, and you really can't test at the time of birth to see if an infant is exposed. And I'll just highlight a couple things here about hepatitis C because I think it's important, and I think it's been missed kind of recently. We use some data here locally to look and see what proportion of infants who were exposed had been tested for hepatitis C in their first 2 years of life. Only 22% have been tested. We found that Black infants were 60% less likely to be tested than Caucasian infants. And this was after accounting for a slew of factors, including where you live, how many well visits you went to, and what hospital you were born in, just suggesting that systemic racism plays a role in identification and testing of infants. To sort of push this home further to understand, well, what's been happening with pregnant people recently and how have communities affected this, we did some work here recently published in the late fall looking at hepatitis C infections among pregnant people. So this is using US birth certificate data. And here you see a similar pattern from where I showed before, where you see higher rates of hepatitis C infections among pregnant people in Appalachia. This is the middle part of the map, and then the upper Northeast. But if you sort of unpack this a little bit, we've seen an increase in hepatitis C infections among pregnant people that's doubled from 2009 to 2019, but it hasn't done this evenly. And honestly, we looked at this, the breakdown of hepatitis C, very similar to the way it worked of Case and Deaton, to look at the role of education in part. So here's what we've seen. We've seen more of an explosion of hepatitis C among American Indian, Alaska Native pregnant people, followed by non-Hispanic white populations. When you break it down by education, we see this stark difference between individuals with a 4-year degree and individuals without a 4-year degree. And this is very similar to a lot of the findings in Case and Deaton's work. We find that this is disproportionately occurred in rural communities in terms of hepatitis C rates per 1,000 births. I want to get back to kind of like the role of communities. In this study, the way that we looked at it was to look at among the highest risk population, so non-Hispanic white pregnant people and American Indian Alaska Native pregnant people without a 4-year degree were the highest risk of having hepatitis C infections. And we wanted to understand what community level factors mattered. We looked at several factors, including the proportion of OBs, accounting for individual level factors. At one point in the evaluation, the proportion of religious institutions to try to get at social network. And time again, the thing that we find are jobs really matter. So this is looking at among this highest risk population, the 10th versus the 90th percentile, using predicted marginal means of our modeled findings. And you see that among this same highest risk population, if you lived in a county with the proportion of folks that are employed at the 10th percentile, you had a much higher risk of predicted risk of contracting or having hepatitis C than if you lived in a county with a much higher employment rate. Again, just showing how these things matter to come together. So as we sort of like begin to get, and I realize I'm talking pretty fast, but to get towards the broader context, we talked about communities, but I also think that other bigger context is important too, that maternal drug use doesn't occur in isolation. It often occurs in the context of poor health, poor nutrition, food insecurity, poor prenatal care, social stress, intimate partner violence. It's important to know that each of these factors associated with poor obstetric outcomes, and each could affect neurodevelopmental outcomes. And I think this is important and oftentimes not accounted for in a lot of the research that we do, not just on birth outcomes, but also certainly on long-term outcomes. The other thing to know is that pretty consistently in the literature, trauma and toxic stress appear to play a strong role. Trauma is common among women in treatment, about 74%. In one study report sexual abuse, similar amount emotional abuse, and half physical abuse. Looking at the adverse child experience literature, adults with greater than 5 ACEs compared to 0 are 8 times as likely to have had lifetime substance dependence and 10 times as likely to have ever injected drugs. When we sort of take all this together, communities matter, jobs, community, healthcare access, but context matters too, poverty, trauma. And the systems that we develop, if we think about public health solutions, really need to understand these underlying issues, have trauma-informed systems, think about economic development as a tool to empower communities and people. The last thing I'm going to mention are child welfare changes, and I'd be interested to hear a little bit about what you all are seeing too. Here's a report from the Assistant Secretary for Planning and Education at the U.S. Department of Health and Human Services. Infants account for 20% of all annual foster placements in the U.S. and is growing faster than any other age group. Most infant foster placements are at least associated with parental substance use. And that has been increasing, certainly as we've seen in parallel with the opioid crisis. Again, looking at state by state variation here, you see substantial variation. And again, you can draw your eyes to West Virginia, where about 4% of infants in the state of West Virginia are in foster care, a pretty staggering amount of infants where we see placements occurring. So in part because of this rapid rise, we've seen several federal changes to try to address this, the crisis. This is a very texty slide, but in 2016, the Comprehensive Addiction and Recovery Act passed, and it was in response in part to the changes to it were in response in part to a series of congressional hearings that followed infants diagnosed with drug withdrawal and found found increased risk of death in the months following discharge. So the Comprehensive Addiction and Recovery Act modified the nation's kind of foundational child welfare legislation, CAPTA, the Child Abuse Prevention and Treatment Act, that every infant who goes home that's substance exposed should have a plan of safe care, and it requires states to address the health and substance use disorder treatment of both the infant and the family or caregiver, so not just focusing on the infant, and that states were required to create a plan to monitor that they're actually doing this. Unfortunately, we haven't seen a lot of movement in this space. Here's what a plan of safe care is supposed to look like. This is another modification from legislation in the space. A plan of safe care, ideally, as it's written in the legislation, is supposed to begin to work prenatally and certainly at the time of discharge to provide wraparound services for families, engaging the Child Welfare Agency, substance use treatment, early care education, Medicaid, public health, treatment, the courts, home visitation, and IDA Part C. These are early intervention services. This is an overwhelming slide for anybody thinking about the number of caregivers in the space, the folks that we're trying to engage with. And largely, at least in our own context, this really isn't happening. And I think there's a lot of worry that what this has led to instead is a focus on over-identifying infants at the time of birth, because we do what we usually do in health systems. We can identify infants, but we aren't necessarily well versed at connecting to all these services, particularly without resources to do it. So there's a lot of concern right now that what these have done has been casting a wider net to identify infants without providing a lot of these services. And some groups are certainly looking into that. Right now, this is being reauthorized. Here's what we see is at least being talked about on the Senate side. Plan of safe care and Senate legislation is being changed to family care plan with the idea that a family care plan feels more family centered. You're not going to a family to say, we need a safety plan for you, as opposed to we're now saying we want a family care plan. Some of the specific language has been really confusing for states, is being modified from affected by and withdraw to substance use disorder. So many states right now have been trying to figure out, what does an infant that's affected by a substance mean? That's really the only guidance that they're given. What does affected by mean? And that has no clinical meaning, and certainly state governments have really been struggling with that. So this provides greater clarity, at least in the version that was public a few months ago, focused on substance use disorder. And it allows for an agency aside from child welfare, to begin to create family care plans. So the question is, like, can we begin to create family care plans that engage all those groups without immediately engaging the child welfare system? Can we provide, let public health really take the lead and thinking about creating these systems to begin to address a lot of these things? Okay. That was a pretty rapid going through kind of the continuum of pregnancy, but I wanted to give us a good place to start talk. Pregnant people and infants have been substantially affected by the opioid crisis, and they really need specific approaches tailored to their needs. Oftentimes, they're really forgotten in that context. Improving outcomes begins before birth, including accessing treatment, but that's pretty tough, at least in the US right now. This isn't just about drug use, it's about the community, economic opportunity, social network, and trauma. I'm an optimist. I think that the opioid crisis has been a vehicle to improve maternal child health. It's bringing people together that oftentimes haven't been. And my hope is that that will lead to innovative change as we move forward. I want to thank my collaborators, many folks that I mentioned along the way. I mentioned their work along the way, and certainly our funders from NIDA to CMMI. And I'm happy to take questions, and here's my email address too. And I will once again apologize for my fast talking over caffeinated self.
Thank you very much, Stephen. It was a great talk. I'll open it up for questions. And while people are thinking, maybe I'll start with one. I was very struck. I've been working with the Ministry of Health here, and they did a scoping review on the evidence to on models of integrated care for mother-infant dyads. It was mainly focused on postpartum in the context of opioid use, and really not a lot of evidence to draw on. Lots of pilot programs, some of which, if you did back of the envelope calculations, seem to be cost effective, like in terms of if you know how much child apprehension costs and child welfare costs. So I'm just curious about whether these state mandates now about safe care mean that potentially a really big, like randomized control trial is no longer in the cards, or what you think about, how you can generate some of this, evidence to like inform policymakers, knowing that there's like a pretty good chance that, measures may not just be the right thing to do, but actually may also be cost savings, which will help, catapult them forward.
Esther, it's a great question. So a couple of things about this. So there have been policy changes. It's not clear to what extent they're actually being implemented at the ground level. A lot of these requirements are to states, not to providers and not to hospitals, and they haven't come with a lot of money. There's a lot of kind of underinvestment systematically throughout the entire continuum in child welfare, and we see that here. So the largely what we've seen in plans of safe care, if you look at kind of what's being reported federally, is that there just isn't a lot of action. So I don't think this is going to make randomized controlled trials obsolete. And I do think we see some programs. So another law that's passed in the midst of this is something called the Family First Prevention Services Treatment Act. It's a bit of a mouthful as well. And it has explicit requirements for evidence. And we see it very similar in home visitation, where they want randomized controlled trials. They sort of, even the legislation talks about what's the level of evidence that's there. And I think we're in a bit of a tension. So, you mentioned like the literature has a bunch of pilot projects. It has a lot of like, there's some QI, there aren't a lot of randomized controlled trials. And I think we're in this tension of how much evidence is the right amount of evidence? How do we evaluate it rigorously? How can we sort of move towards, yes, we want RCTs, but can we use some quasi-experimental designs? Can we do some other things that are there to really try to get at and advance the science a bit more? I think the other thing that I see in this space commonly are silos in research. We see medical research focused on medical outcomes, but a lot of these programs are really looking at other types of outcomes. So for example, if I'm studying medications for opioid use disorder, I'm probably going to look at birth outcomes. One of our studies, we're actually looking at foster care placement at 1 year, in part because we're trying to look at these other types of outcomes to provide evidence for human services programs that may need evidence. So I think we certainly need more evidence, and we need more investment in getting that evidence. And we need to be kind of thoughtful and strategic about how we evaluate the level of evidence that's needed.
I agree, but interested to hear. And do you think, I think even for some of the quasi-experimental, this takes, I mean, these are large, these are large projects, right? Do you get the sense that they're on the table?
Yeah, so I do. And there is a center that I'm a part of at RAND Corporation that's doing some work, mainly adult focused, but focusing on evaluating state opioid control policies and trying to advance the methods for that, including causal inference and other things like that, looking at kind of how we've done it in the past, what appears to be biased, and what potential approaches might be. So yeah, I think that's on the table, and I think there's a real need to advance, because I don't know that we can wait for, this is dangerous to say, right? We need RCTs, but in the absence of RCTs, waiting for 10 years of follow-up, we're going to have a lot of lives lost, so we need to be thoughtful about using existing data in rigorous ways. And I think part of it is being transparent about the limitations of the data, the methods, having kind of nuanced conversations, which can be really hard in the space of, here's what we see in the data, here's what we don't, here's the limitations of the approach. But I think kind of, if we rely on RCTs exclusively, I think we're going to be stuck for a long period of time. Doug, you look like you had a question.
Yeah, thanks, Stephen. Doug Campbell. I work at SickKids a little bit, but also downtown in a large urban hospital where we see a lot of this. I'm also a neonatal person as well. So thanks for bringing this. And obviously the group here is very interested in that. I really like how you mentioned communities. And I think what I've noticed being a pediatrician working in a large adult center, and with children and families like this, is you really do need that community approach, right? From a prenatal point of view and prior to prenatal, obviously, and this is challenging, right? And I think this is what makes it so hard. I mean, the silo between even, pediatricians or researchers and maternal care providers is still pretty big. And the community that supports them is pretty disparate, at least it is in Ontario and Toronto. And what applies in downtown Toronto probably doesn't apply in downtown Kingston and Northern Ontario. And the race and stigma that exists is so severe. I think we can't wait for the cluster randomized RCTs. I think we have to start. And that's hard, right? And that's really challenging because we need approaches that work for communities. And a lot of it, I think, is based on trust at the clinical care level. And then how do you extend that on to the research so you have interventions that could be broadly applied? It's a real challenge, I find.
Yeah, I would say this. So we have locally, we've done some work to try to break down our local silos. So we have a program that's funded now from the Centers for Medicare and Medicaid Innovation to try to innovate in this space. And it's not a randomized controlled trial. They're going to do some external evaluations of it, but it's a partnership between OB, psychiatry, pediatrics that begins with treatment prenatally, addresses social determinants of health, and goes to 1 year postpartum. And we'll see where that goes. We have built kind of a quality improvement framework with it. I think that's what we're going to have to do in many of these spaces. It gives me a little bit of heartburn, right? Because you can so easily cause harm in this space too. And so being cautious and thoughtful, and I think it requires kind of ongoing conversation and evaluation.
Teresa?
Hi, thank you. Great talk, Stephen. I have two questions. One is related to paternal exposure. We focused on maternal exposure, which is rightly so, but I wonder, what your thoughts are on the impact of a paternal exposure. There are animal studies that show that exposure to drugs like cocaine could really have a detrimental effect on neurodevelopment through epigenetic mechanism. So if that's true in humans, if we look at the opioid crisis, focusing on maternal and child outcome, are we really underestimating the crisis? So that's question number one. The second question is NAS and also fetal alcohol syndrome. The two must be highly correlated. So I wonder how much of the impact that we are seeing could be solely attributable to NAS, and how much is to FAS, and how much is to both?
Those are both really great questions. So let's first talk about the paternal risk factors. Honestly, I'm not aware of data in the space on dads and their potential, how their exposures may influence. It makes sense, like the pathway you described makes sense to me. I will say that I think we do a poor job both in data systems to identify dads, to understand the exposure. And so some of what I think we see are the limitations in the data and the approaches, but some of it's also intentionality. When I talk to my human services folks, like they oftentimes will say, well, what about the partner? So thinking about the partner, not just in terms of understanding risk, but also in engagement. I do think we have to be cautious in that space because oftentimes the partner is a perpetrator of violence too. But I do think we need to be thoughtful about how do we engage partners, both in terms of research and risk, as well as interventions moving forward. The question about alcohol is really important. So FASD, fetal alcohol spectrum disorders, as you know, can be really challenging to diagnose until later on. So we know that there's under recording of FASD, right? We miss it. So to that large degree, there may be kids that don't meet various like thresholds of whatever, but there is co-use of alcohol. And some of our work this was using data from the National Survey of Drug Use and Health of people who misused prescription opioids. This is using their old definition of that. So just taking it not as prescribed. About a third also used alcohol. So yeah, it's common and it's underdiagnosed, and it's underdiagnosed at the time of pregnancy, but also beyond. And so I think you're right that that likely when we look at long-term outcomes, some of the opioid effect that we see is probably alcohol, but it's not just alcohol. It's also that one slide that I presented about poor health, toxic stress, like all of those things probably matter. And this is where we do need, like stepping back from the policy conversation, what do we need with science? We need large prospective studies that follow the exposures long-term that begin to disentangle this. I don't think we can do this with secondary data analysis. I don't have confidence that causal inference is really going to tease this out. There really does need to be. And so right now we see kind of a large NIH funded study. I think it's got 10,000 HCBD. I'm going to mess up the acronym, but that's going to follow a cohort of around 10,000. And I think that's really what's needed in this space to begin to tease that out. And I would say that hopefully we fix the opioid crisis now, but there's going to be other substance. We need paths. We need data 10 years from now too in space.
Thanks. There's a comment, Stephen, in the chat just about some other work using quasi-experimental methods to evaluate policy effects around reproductive health. So thank you, Michelle, for that. Any other questions? Oh, Eyal.
So thanks for an excellent talk. I actually have a kind of sociological question about this. So I'm involved in a project with some colleagues in Northern Europe around opiates in children and risks of accidental exposure with one of my colleagues, Ron Finkelstein. I don't know if he's on now. And they were commenting in like a review of the manuscript around words like opioid crisis actually being irrelevant in their particular context. And I've read other stuff from other European jurisdictions that say the same thing. So just a question to you, we're pretty far out from Purdue and the 1990s, early 2000s when a lot of this happened. Why is this such a sticky crisis, particularly in the US and also in Canada? And why particularly in the regions like that you alluded to, when we know that other drug crises have had effects in other parts of the country and other jurisdictions around the world?
That's a great question. So when we look kind of like countrywide, US, worldwide, sorry, it is pretty consistently the US, Canada, parts of the UK and Australia. That's where we see this. I don't know kind of perfectly why. I think there are similarities between all three that we can sort of we can see. I will say this, that the question about why haven't we moved on from what started as a prescription opioid crisis? And part of it has been, we certainly, there's evidence that we had folks who went from prescribing to other types. So we had a whole series of laws that were really supply side. So we focused on decreasing the supply of prescription opioids, and we rose up the price of prescription opioids. It became harder to get, and getting heroin initially was cheaper and easier. Still today in the US, it's easier to get fentanyl and heroin than it is treatment in many communities. So I think that's part of this calculus. Like we have cranked down on the supply. At the same time, we have heroin that's cheaper, fentanyl that's even cheaper in communities to transition to. But now, of course, we see primary use, and we see people starting to use with fentanyl and heroin, and it's shifting. I think part of it is readily available. Fentanyl is incredibly cheap to produce synthetically now, and I think part of that may be driving the market too. So I think it's complex. It did start with prescription opioids. The part of the transition was related to supply side changes and the focus on just getting that down. But in the midst of that, we kind of missed an opportunity to enhance access to treatment and to address many of the underlying issues that we talked about. Whether it's economic opportunity, whether it's social network, whether it's kind of like all of those things probably matter to a certain degree.
Housing
is important too. Yeah.
Income inequality.
Yes.
Right.
Yeah. I think you're talking. You may be muted there.
So I'm just struck, even in the US, why Appalachia? Like there are income inequalities in every state in the United States. And the rates, that you showed in your graphs are quite dramatic. Maybe it's just once it anchors, it's really, really hard to eliminate, but it is pretty striking how regionally focused it is from the data that you showed.
It is. And I would say, I was in West Virginia 2 weeks ago, And the amount of poverty is pretty striking. And I think it's hard to discount how much that has played a role. And we can look back through various crises, whether it's meth and beyond, like that certainly has played a role. Like there is not the same level of opportunity. I would also, the other thing it's worth mentioning, and I didn't have I cleared up some slides to try to be briefer, believe it or not, that the other thing that we see is this sort of we're missing issues of equity when it comes to Native American Indian, Alaska Native populations, and also non-Hispanic Black families too. In some of our work, when you compare urban white pregnant people to rural Black, Hispanic, and non-English speaking patients, they're less likely to receive medications for opioid use disorder, for example. And so I think in this next phase of the crisis, like as we're sort of like playing, how are we going to address those issues of equity as they play out in communities too? Because that sort of intersectionality of in rural communities, I think can be really substantial for individuals.
I mean, here, I think there's also, sorry.
You guys take care of yourself. Sounds like a fire alarm.
It's a code gray. I have no idea what that is. Al and I are both in the same building.
Code gray means system failure.
Oh,
Yeah.
My favorite here is a code walker when there's a patient walking that's escaped, like not in the elsewhere.
Code gray summarizes the maternal opioid approach.
I think that's good.
Yeah, exactly. Yeah, I think here also, I mean, conversation certainly around intergenerational trauma, particularly in the First Nations and other Indigenous communities, is a big part of, I think, what people think. Yeah. So thank you very much. I don't see any other questions. I know a few of us are going to stay on for a few minutes, but anyway, really a very warm thank you, Stephen. You're doing amazing work, and we will look forward to reading about some of the interventional work that you're doing. We're not randomized control trial snobs, so we will take all the good evidence as it comes. And really, thank you very much for a fantastic presentation on a really important topic.
Thanks for having me. Good to see you all.